Hello everyone, welcome to my YouTube channel. Today I am going to talk about part 2 of necrotizing fasciitis. In this video, I will cover regarding HBOT, hyperbaric oxygen therapy, and other questions. Before we start, there is always a disclaimer, and the disclaimer is the same in all my videos. Thank you. Now let's begin. Again, what is necrotizing fasciitis? Necrotizing fasciitis is a soft tissue infection characterized by rapidly progressive necrosis of fascia and subcutaneous tissue with relative sparing of underlying muscle. Necrotizing fasciitis may occur in a wide range of anatomical locations. Example, in the scrotum, it is called fournier gangrene. The key therapeutic intervention is immediate and radical surgical debridement of all that tissue with prompt administration of broad-spectrum antibiotics and appropriate high-dependency supportive care. Even with early aggressive surgical debridement and appropriate antibiotic treatment, mortality rates are high. It's around 40%. So question, any role of HBOT, hyperbaric oxygen therapy, in treating necrotizing fasciitis? Before I answer this question, I will introduce you regarding HBOT or hyperbaric oxygen therapy. Hyperbaric oxygen therapy involves therapeutic administration of 100% oxygen in a pressure chamber at pressure above 1 atmosphere absolute. This increases arterial oxygen content and thus tissue oxygen pressure. The risk of adverse effect involved in HBOT, even though it is rare, are A. Pressure-induced damage, barotrauma to the middle ear. B. Acute brain oxygen toxicity, where patient may develop seizure. C. Pulmonary oxygen toxicity, whereby patient presented with cough. D. Temporary worsening of short-sightedness. The aim of hyperbaric oxygen therapy is to increase supply of oxygen to the affected area, thereby salvaging critically ischemic area. Hypoxia potentiates antibiotic efficiency. It also improves the white cell killing efficiency and stimulates an anti-inflammatory action. Back to the question, what is the role of hyperbaric oxygen therapy in regarding necrotizing fasciitis management? Hyperbaric oxygen treatment is controversial. Literature systemic review done by Levitt et al. In 2015 does not support or refute the effectiveness of hyperbaric oxygen therapy in management of necrotizing fasciitis. I can conclude that the treatment of HBOT in necrotizing fasciitis depends on the attending surgeon. For future therapies, the role of intravenous immunoglobulin IVIG in the treatment of necrotizing fasciitis, especially if associated with group A streptococcal infection, is highlighted by a study done by Anaya et al. The author concluded that the use of IVIG seems rational in patients with group A streptococcal infection who develop streptococcal toxic shock syndrome and in those patients with a high mortality risk. Example, in patient who is in advanced age group, hypertension patient, and bacteremia. The problem with this study is that it has a small number of patients and there are different methodologies used. Difficult to compare. So there is a study by Wang and Wang et al. It shows a clinical characteristic of necrotizing fasciitis. as an additional note, in early stage, stage 1, patient may present with erythema, swelling, warmth, tenderness, and fever. For stage 2, intermediate stage, patient will present with blister and bullae, skin fluctuance, skin induration. For stage 3, late stage, patient will present with hemorrhagic bullae, skin hyposensitivity or anesthesia, crepitus, tissue necrosis progressing to gangrene. So the question is, why hyponatremia occur in necrotizing fasciitis patient and is involved in one of the RENET score? So firstly, let's define hyponatremia. Hyponatremia is defined as a serum sodium concentration less than 136 millimole per liter. It can be divided into A. Mild hyponatremia, whereby the serum sodium concentration is around 130 to 135 millimole per liter. For moderate hyponatremia, the serum sodium concentration is around 125 to 129 millimole per liter. C. For severe hyponatremia, the serum sodium concentration is less than 125 millimole per liter. Why hyponatremia treatment is important? So the reason hyponatremia requires treatment is the relative excess of water will lower the serum osmolality, causing a shift of water into cells until new osmotic equilibrium is reached. Although hyponatremia will cause all cells to swell, brain cell swelling is dangerous because of its rigid box of skull limits the space for expansion. The problem with hyponatremia for the brain are two. One is cause cerebral edema if hyponatremia develops quickly, for example in acute hyponatremia, or osmotic demyelinization if the chronic hyponatremia is corrected too quickly after brain cells have adapted to their hypotonic environment. Water balance regulation depends on the brain and kidney communication. It depends on an interaction between specialized sensors that translate the signals they receive, example, high serum osmolality, low effective circulating volume, to the central release of vasopressin, the antidiuretic hormone ADH, into the circulation, which then stimulates water reabsorption in the renal collecting duct. So again, the question, why hyponatremia occur in necrotizing fasciitis? Necrotizing fasciitis leads to sepsis that gives stress stimuli to the body. In septicemia condition, there is vasodilatation due to release of nitric oxide, NO. This will cause low blood pressure due to low preload. Compensatory action is the body will trigger vasopressin, ADH, antidiuretic hormone, to be excreted more into the circulation. This will stimulate absorption of water into the renal collecting duct, whereby more aquaporin channel is open. This causes more water to be absorbed to increase the preload. Hyponatremia is due to dilutional effect that occur because of the compensatory action of the body towards stress and low blood pressure. Okay everyone, that's all for today. I hope you have learned something from this video. Till we meet again in the next video. Bye.